Thank you, Dr. Holland, for nice review of claw. I prefer slate. I do not have any financial interest. You see, this is the patient referred 2013, and it is a bilateral injury. One eye is absolutely 360 degree, but other eye, there are some areas of LSCD. And what are the treatment options? So it is claw, it is slate, maybe PK later on. I did slate in this in 2013, and this patient gradually improved, and over a period of 6 months, this patient is doing fine with 6-12 vision, with pupillary axis clear. So this is the pre-op to post-op within a matter of, now this is almost 18 months. So slate is a more recent procedure described by Shangon et al. And we have to remove only 2 into 2 or 3 into 2 millimeter limbal tissue from the healthy donor eye. It is like claw, it is a single stage procedure. Of course, it doesn't require any sophisticated lab support, least expensive, and probably it doesn't cause any iatrogenic LSCD of the donor eye, which may happen, but Dr. Holland had already shown that their data shows no recurrence of limbal cell deficiency, no occurrence of limbal cell deficiency. It is the indication is same, unilateral limbal cells deficiency, and you need to know the diagnosis, how to diagnose it. And you have to see the unilaterality and take the good examination of the good eye and look for the contralateral donor eye. And this is the ideal candidate. And ASOCT is also important to know the exact thickness. And if it is, even it is same true for claw surgery. So otherwise you might lead into the perforation. So classical indication is alkali burn. We see a lot of tuna packet, like this lime burn injury in our country. And these are the cases where mostly children, and we do under general anesthesia in these cases. And this is post-op 1 year, post-op. There are some areas of little remnant of tissue. And if you see that the surgery is very simple, if you see that you can, the same way you have to do in claw also, you have to clear the panas and the superficial, you get a cleavage plane with some blunt instrument, and gradually you have to clear the cornea, and then you have to take the limbal tissue. It is simple, just you need not to take the conjunctiva that much, but sometime if you may include 1 or 2 millimeter conjunctiva along with it. So this is the harvesting of the tissue, just 1 o'clock hour. Then you cut pieces of this tissue, and with a sharp 15-degree blade, you cut it and make it multiple pieces of 8 to 16 pieces, and at the same time you prepare the donor recipient area with amniotic membrane. You place the amniotic membrane, use the T-seal glue, and you just put this thing over the just over that glue, and 12 to 16 pieces, and you just avoid the pupillary area. And after this, you just put a bandage contact lens. So slate also works equally well in thermal burn, iatrogenic LSCD from multiple surgeries, unilateral LSCD caused by toxicity of the medication and preservatives. This is the one case with thermal burn. The central pupillary area much clearer than before. This is with the sympleferon, and you see that these are the cases where you need to do later on DALC or PK, like Dr. Holland said, that the same. You can later on do a DALC or PK in these cases. Techniques has a little modification. It is an evolutionary process. So explant on amniotic membrane, explant on cornea and sulfates, double sandwich technique, mini slate for pterygium, top of slate or reslate procedures, all are described. And literature, gradually the literature reports are coming, and you can always redo this procedure. And this is the typical double pterygium. You can also use this one side, you can use the corneal autograft, and other side maybe slate. And the multicentric trial already shown that it is reproducible. And as Dr. Holland is rightly saying, that it is the long-term data is not only we have 12 to 13 months data in the published one, but personally we have now almost 4 to 5 years, and many of these patients, at least 70 to 75% patients, are doing good. Some of the cases people are trying living-related slate. Though it requires same as systemic immunosuppression, like this case, it is doing, I mean, these are the extreme cases where they cannot pay for money, but these patients can do well. Then these are the bilateral acute chemical burn. You see that this report came in British Journal last year only, and here the idea is to keep the surface better. Later on, you can do a better job. No immunosuppression in this particular group. SLATE does not work in LSCD caused by VKC, LSCD caused by contact lens induced, or immunological drag like SGS or MMP. The case selection, surgery, good workup and planning is important. So patient selection, it is the same. Donor eye selection, I mean that way, that unilateral, the donor eye should be absolutely fine. Patient workup, you need to know the glaucoma medication, you know to know the use of systemic or other comorbidities. And it includes all, like lead function is also important in these cases. So causes, there are causes of failure, presence of symblepharon. It is more, right now the reports are coming. There are certain issues like hemorrhage under the amniotic membrane, non-adherence of the limbal grafts on the corneal surface, early loss of BCL in case of children where we are like to do sandwich technique, like these are the subamniotic hemorrhage, BCL loss. You see the wrinkling of the amniotic membrane, probably this SLATE will be failing. So we are trying to, and these are the cases where still residual focal peripheral pannus is there. If the patient wants, we can redo the surgery. And already described, there are a lot of difference, but definitely CLAW has a long history, SLATE has a very small history of 4 to 5 years. And recent publication shows that though this is not randomized control trial, but they have grouped together, they said that both are equally special union ocular, chronic ocular burn. The advantage of SLATE that you could redo the surgery after 1 year because you are taking very small amount of tissue. So this type of cases where you have like some degree of already LSCD, even in healthy eye, you can take little amount of tissue and you can do a good job. So take-home message is SLATE is an inexpensive single-stage procedure for unilateral LSCD. Classical indication like unilateral chemical burn, case selection and healthy eye limbus are important for success. With time and experience, we are learning a lot and indications are expanding. Repeat SLATE is possible without any danger to the donor eye, which may not be true in CLAW cases, but for immunological cases, SLATE doesn't work well. Thank you very much for your patience here.